Hi, this is Andrew Wolf. In this video, I'm going to talk about glomerular filtration, and I want to start by talking about just a little review of the anatomy of the glomerulus. So, the glomerulus is interesting because it has two arterioles, one feeding into it and one moving away from it. Now, as you know, usually when there is a capillary bed, there's an arteriole feeding into it and a venule leading away from it. But the glomerulus is unique in this fact. It has an afferent arteriole and an efferent arteriole. And the glomerulus is a tuft of capillaries in the middle. And the capillaries are uniquely adapted. So let's talk about a few things. So the afferent arteriole, of course, just like all other arterioles, has smooth muscle around it, and it can change the diameter. If the smooth muscle contracts, that's going to increase flow, and if it constricts, it's going to decrease flow. If yes. So if it contracts and vasoconstricts the vessel, it will decrease flow. If it relaxes and dilates, that will increase flow. Now, the efferent arteriole also has smooth muscles. And this is interesting because what we have here is we have a pipe. Here, let me move over a little bit. Move over in this direction. So what we have here is, we'll talk about plumbing here for a minute. We have a pipe, and we can control the flow into the pipe by opening and closing a valve. Draw a little handle for a valve. So if we open the valve, this will increase flow. If we close the valve, it'll decrease flow. Now, the efferent arteriole also has a valve. Now, what's interesting with the efferent arteriole is it really has more to do with pressure than flow. And obviously, flow and pressure are very closely related. But since we've got a third pipe here that we're going to talk about in a minute, it ends up being that if you turn this valve, you're essentially affecting flow through the glomerulus. I'm just going to make the glomerulus one little blob there. And if you change the pressure in the efferent arteriole, if you change the valve in the efferent arteriole, you're essentially going to generally change pressure in the glomerulus. Now, the glomerulus is filled with little pores. And we have another little pipe leading away here, and this is of course Bowman's capsule, and which leads to the renal tubule. So because we have, unlike anywhere else in the body, we have a valve on the way in and a valve on the way out, we have a lot of control of the glomerular. We have a lot of control over the pressure of the capillary bed. And this is very important because glomerular pressure, the amount of pressure that we exert here, is going to have a significant impact on the filtration. So we can affect pressure and we can affect glomerular flow. And together, these are going to dictate what the glomerular filtration rate will be from the tubule. Okay, so again, I just want you to get the concept, the very important concept that we have a valve on both ends, and that allows us to control pressure and flow simultaneously. And and that allows us to change glomerular filtration rate considerably. And we'll talk about that a little bit further as we go on. So that's the afferent and efferent arteriole and the glomerulus. Now, the glomerulus is interesting because it has specially adapted endothelial cells, and these endothelial cells are fenestrated. So there's fenestrated endothelial cells in other parts of the body. And again, fenestrated is just a word that comes from the Latin word fenestra, that means window. And essentially fenestra are windows that go from one side of the cell membrane to the other side of the cell membrane, like little tunnels all the way through from one side of the cell to the other. And this allows this provides a selectively permeable membrane. Now, okay, so let's say these are endothelial cells, and we've got our blood on this side. So this is a glomerular capillary. Now, on the other side, of course, we have our basement membrane. And this is a selectively permeable membrane. And then it's a very thin membrane. And then on the other side of the membrane, we have what are called podocytes. And podocytes are these sort of, they look like little worm-like cells that wrap around the glomerular capillaries. And they are sort of very tight fitting. They fit together very tightly, and they overlap each other. And what you end up having is little pores. So because they're relatively tight fitting, but there's spaces in between them, so you end up with slit pores. So the fenestrations of the endothelial cells are about 70 nanometers, which is large enough to allow just about all particles in the blood to flow through, except for cells. This is about twice as big as an albumin molecule. However, the fenestrations are sort of surrounded by little protein molecules that are highly charged. And these highly charged protein molecules resist the passage of even relatively large protein molecules. So even though looking at the fenestrations grossly, it looks like albumin and other proteins would be able to pass through, but because of these negative charges, it makes it difficult. Now also, these slit pores are even smaller. They're like 10 to 20 nanometers. And these slit pores, when they are functioning properly, resist the passage of almost all proteins. So it's rare for proteins to pass through from the capillary through the fenestra and through the slit pores. So plasma inside the capillaries is selectively filtered. So the selective filtration allows water and electrolytes to freely pass, but it prevents the passage of protein and other large charged molecules. So what we have is blood flowing in through the afferent arteriole into the glomerular capillaries, and then some of it is filtered out into Bowman's capsule. This is called Bowman's capsule, and that is called the filtrate. And then the rest of it works its way back to the efferent arterioles. Now, the efferent arteriole goes back into another capillary bed. And where does this capillary bed go? Well, it goes and wraps itself all around the tubules. And then after it works its way through the second capillary bed, it goes back to the renal vein. Okay, so let's talk about this glomerular filtrate. The glomerular filtrate is the fluid that is pressed out of the glomerular capillaries under pressure, under the glomerular pressure, and into Bowman's capsule, which then drains down into the proximal tubule. So glomerular filtrate. Well, glomerular filtrate, again, is similar to plasma, but without protein. Now, glomerular filtrate, we make about 125 milliliters of glomerular filtrate per minute. Now, let's talk about some flow here. So, what depicts how much glomerular filtration we have? Well, the glomerular filtration rate, GFR, glomerular filtration rate is equal to renal plasma flow times the filtration fraction. Now, what is renal plasma flow? Well, plasma is about half of blood, right? So 50% of blood is plasma. So plasma flow is going to be 50% of the blood flow through the kidneys. How much blood flow is there through the kidneys? Well, our cardiac output is about 5 liters per minute. And about 20% of that goes to the kidneys. So we have about 1,000 mLs per minute of blood flowing through the kidneys. And 500 mLs of that is plasma. So we have about 500 mLs per minute of plasma flowing to the kidneys. And under normal situations, 125 mLs per minute is made into glomerular filtrate. So the filtration fraction is usually about 25%. Now, this can change considerably, and we'll talk about how in a minute. So, what can we do? How does our body change glomerular filtration rate? Well, glomerular filtration rate is going to change if we... All right, I'm going to talk just about how do we increase glomerular filtration rate. So we're just talking about one direction now. We can increase glomerular filtration rate by increasing plasma flow. How do we increase plasma flow through the glomerulus? Well, one way is obvious. So let's talk about increasing plasma flow. The first way that we can do it is by increasing cardiac output, right? So by increasing cardiac output, if we go from 5 liters per minute to 8 liters per minute, then obviously we're going to increase this 1,000 mLs per minute to about 1,600 mLs per minute, right? So increasing cardiac output itself will have a significant impact on the amount of blood flow to the kidneys. Now also, the other thing we can do is increase the amount of blood flow that's going to the kidneys itself. So we can increase this from zero point 0.2 to maybe 0.25. How would we do this? Well, we would dilate the afferent arterioles throughout the kidney. And dilating the afferent arterioles would increase blood flow to the kidney. So that would again increase it, the blood flow to the kidney, considerably. Okay, so one way to affect glomerular filtration rate is by increasing plasma flow, and we can do that by increasing cardiac output or increasing output, increasing flow just to the kidneys by dilating the afferent arterioles. Now, how can we impact filtration fraction? Well, if we want to increase the glomerular filtration rate, then we would need to increase the filtration fraction. So we would need to increase this normal 125 mLs per minute, or 25%, to maybe 40%. Now, how would we do that? Well, the easiest way to do that is to increase the glomerular pressure so the pressure in the glomerulus, and the easiest way to do that is to vasoconstrict the efferent arteriole. Okay. Now there's some other factors that that can change the filtration fraction, but this is the easiest way for the body to make a significant change. Now, obviously, you're going to change the filtration fraction by changing the relationship of pressures between the glomerular capillary and the pressure in the Bowman's capsule. And obviously, hydrostatic pressure, the pressure from the arterioles, is going to have a significant difference. But the other factor that you need to consider is the amount of proteins, the amount of colloid or oncotic pressure that is tending to pull fluid back into, down its concentration gradient back into the glomerular capillaries, because remember, there's more proteins in the capillaries. So let me just draw you a picture here. So we have here a capillary, and because there's a lot of flow here, because the afferent arteriole is dilated, and there's a lot of resistance here because the efferent arteriole is constricted, we have significant amount of hydrostatic pressure that's pushing out into Bowman's capsule, right? But at the same time, we've got lots and lots of proteins here that can't get out. So there's a high concentration of proteins. Electrolytes really don't matter here because they're the same on both sides, right? The electrolytes are going through that selectively permeable membrane. So because there's a high concentration of protein, we're going to have osmotic pressure, but when we're talking about osmotic pressure in regards to protein, it has a special name. It's called oncotic pressure. So we have pressure pulling back in towards the capillary. So obviously, changing the filtration fraction is really going to be dependent on both these factors, the oncotic pressure pulling things back in and the hydrostatic pressure pushing things out. Now, there is also some pressure, there is also some hydrostatic pressure pushing things back in, because there is some fluid pressure within Bowman's capsule, but it's relatively constant usually. It's around 30 millimeters of mercury, whereas the hydrostatic pressure coming from the cap from the glomerulus is around 60 millimeters of mercury. But it is important to recognize the importance of this oncotic pressure as a variable because there are some diseases, for instance, imagine if you have hypoalbuminemia and you don't have much albumin. What's that going to do? Well, it's going to decrease the amount of oncotic pressure. So forces are going to favor an increased glomerular filtration rate, right? But say we've got another situation. Say we've got damaged glomeruli. Now this is not uncommon at all. People that have um, high blood pressure for a number of years end up start to damage their glomeruli, and they actually start to leak proteins into Bowman's capsule. So imagine if we start leaking proteins into Bowman's capsule. That is also going to decrease the oncotic pressure or the pull back into the glomerulus, and it's going to increase glomerular filtration rate. Now, this is interesting because this is a patient that's in early renal failure because they've damaged their glomerulus, but in early stages you have increased glomerular filtration rate, and that in part is due to the fact that you have significant proteinuria. So oftentimes you'll have a patient that has normal urine output, normal creatinine clearance, but they have proteinuria, and that is an early sign of renal failure, even though everything else is normal so far. Eventually the glomerulus will get so damaged, and actually many of the glomeruli will actually be completely ineffective or scarred in, and then over time you'll end up with decreased glomerular filtration rate. And we'll talk about that a little bit more when we get into acute and chronic renal failure. Okay, so that is my very brief introduction to the glomerulus and the formation of glomerular filtrate. In the next videos, I will start to talk about the formation of urine from filtrate. Please, if you want quick and easy access to my other videos, please click on one of the links below. And as always, I'm willing to answer questions if you want to put questions in the comment field. And also, please provide feedback by clicking on the like button. Thank you very much.